Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humor and a lot of heart. So pull up your chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins.
I am Dr. Rebbecca Hertel. I'm a board-certified osteopathic family medicine physician and a Menopause Society certified practitioner. I have a private telemedicine practice, and I see patients in several different states.
I am Dr. Aoife O'Sullivan, a board-certified family physician and Menopause Society certified practitioner, and I see patients through my telemedicine practice here in Oregon and Washington.
I'm Dr. Christine Hart Kress, a board-certified women's health nurse practitioner and menopause certified practitioner, and I see patients via telemedicine in several states as well.
Welcome back to the Dusty Muffins, where we talk about everything no one prepared us for and how we figure it out anyway. Today's conversation is one we've been really looking forward to because it's about the missing manual for our bodies during the middle years.
We're joined by Emily Sadri. Emily is a board-certified women's health nurse practitioner, a certified nurse midwife, and a hormone expert who founded Aurelia Health. It's a modern concierge telehealth company that serves women navigating the often confusing waters of perimenopause and menopause.
And between her expertise in precision hormone care and her busy home life in the Midwest, husband, 4 children, and 2 dogs included, Emily is the definition of a powerhouse. She isn't just studying longevity, she's living the full plate, lifestyle right alongside her patients. Emily, welcome to the show. Thanks for joining.
Aw, thank you so much, ladies, for having me. That was such a nice introduction.
Yeah. Did I butcher the name of your business as I was trying to get it out of my mouth?
No.
Okay.
It was perfect. It was perfect. It's actually a Greek word.
I was going to ask, where did that come from?
Yeah, it means golden or precious. And I wanted something to feel feminine, a little bit luxurious. And it does feel like the work that we're doing really is quite precious. And it's always was something that was like the shoebox at the back of the closet kind of medicine and care. But I think that much the way that I felt about childbirth and in women's health in that era of life, like if we can get these things right, we can change society, we can change the world. If we can resource women in midlife when they're really they're most wise and they're most capable and able, then we really can change the world and communities. And that is really precious and special work. So that's where the name came from.
So true. Don't you wish you could go back in time and give your 20-something-year-old self all the wisdom that you have now?
Oh my goodness. In so many ways, I would have saved myself so much heartache and pain.
She'd probably argue
and
with
also
me.
Tell yourself not to give so many fucks about things, not to sweat the small stuff.
That's true.
And not to give so much of yourself away to people that haven't earned the right, I think like us as women, especially women who are helpers and who are, naturally drawn to helping others, we just make everyone else's problems our own. And that's called high functioning codependency. I've learned when we're over invested in the experience of others and under invested in ourselves. And that's the most freeing thing because it happens by necessity. By the time we get to this midlife squeeze, sitting between 4 children, Dr. Rebbecca, you have 6. So I can't even imagine, I have elderly parents that I'm supporting, and you can't have time for everyone, right? Even patients who bring extra drama, right? You have a certain amount of distance that you weren't able to have in your early career.
Yes. Because patients can be, you can take on quite a bit when they're coming to you with all of the things too, right? Their own tragedies and struggles and, children and parents and trauma. So yeah. And sometimes that is difficult to shut that down. And then at the end of the day and not to take that home.
I know. I think, working in this space and having our own practices and that freedom to define how we care for women, I have quickly learned that I have a max that I can handle per day. And when I think about it, I'm like, gosh, I used to see over, 20, over 20 patients a day. And that included, getting naked and doing their exams. And now 5 patients, I'm like tapped out, all done, because of all of that emotional piece of this care and being present with women. It's far more exhausting than doing 25 pap smears. Far more.
Just to clarify for our listeners, Christine would usually stay dressed. It's her patients. She will get
maybe.
When we
Usually.
by healthcare, right? You take out the piece that's the nuance, right? You take out the emotional piece in order to make it profitable. I mean, look at, I won't name names, but the largest telehealth provider of menopause care, right? The NPs are rewarded for seeing more than 4 people per hour. There's no time for relationships in that. And I think I love that one thing that all of us share in this room is that we've reached a point in our life where like the quality for us matters, right? It's not just about what we're giving to the patients, but the way that we feel and the experience also matters. And that's awesome. And I hope that every healthcare provider that's listening that maybe doesn't have that knows that that's accessible. And that's like this new era of healthcare that we're moving into. I think that truly like primary care as we know it is going to fall apart in the next 20 years. I think that it's not doing women any favors. Like, what does it even do? Right? It just like serves as a referral factory and maybe a prescription factory. But there's no relationship. There's no preventative medicine happening there. And women are like catching on to that. And so the need for relationship-based practices, like what each of us have built, is just going to climb and climb. And so, yeah, you can do it. That's my message.
Yeah.
So, Emily,
Emily,
I've been following you for a while, and I stalked Emily in the bathroom when we were at A4M. I'm like, "Are you Emily Sadri?" And she's like, "I am," and I'm like, "I follow you." She's like, "I think I follow you too." I said, "We do." I said, "I've been wanting to meet you." I was fangirling in the bathroom, and then I was like, "Can I please go to the bathroom?" So she was kind enough to wait for me outside. But
no, it was so great. I love Instagram for that, by the way. Like,
yes.
I mean, how great is that? Like I think we all lived in our careers in a period of time when we felt so much isolation. When I was a midwife, I wasn't really on Instagram, and I kind of wish I had been,
Wow.
I'm so glad that like we have this way to be like, yeah, there's this other people out there who get it and who are just like us, so it's wonderful. I loved meeting you there. I'm so glad.
Well, and then it was like, I want to hear more because, I think there's different camps in this space. There's the academic camps, and they're fine. And then there are what people call, the traditional influencer camp. And then there are this group of people, which we are all kind of surrounding us, meaning the Dusty Muffins are surrounding ourselves with the people who look at things from a different lens and realize that, the randomized controlled trials are not going to be here. And if we practice just using guidelines, we wouldn't get outcomes for patients. And so I know that you talk a lot about physiologic hormone therapy. And, for those providers that are quick to get to a pill, the pill approach of we can manage your moodiness, we can manage your bleeding, by shutting that all down. There are those camps and, can you explain how your method prioritizes the body's natural rhythms and how you got to that point? Because I know you like that in perimenopause, and I hear from patients that it's very successful for them.
Yeah. So when I started my practice 5 years ago, I had the traditional menopause tools in my toolbox, and I had a fair amount of functional medicine training. And I was trying, like most of us, to just figure it the F out. And I was seeing the same patients in my office every day. And I was trying to use a lot of functional tools with them. And I wasn't getting the results that I was promised by IFM. Like putting them on an elimination diet didn't fix everything. wow, I wonder why. These women were having Brussels sprouts and their blood sugar was spiking up to 140. Like, make it make sense, right? Like, why is that happening? That is, the woman is not broken. Like, I know that she's trying so hard. And I was also 40 years old and postpartum with my fourth baby. So my HPO axis was suppressed and I was insulin resistant, like very insulin resistant. And nothing I was doing was working. Like, no amount of, 50 grams of carbs a day still wouldn't change my fasting blood sugar. It was insane. And I was like going crazy. Some of you have probably been in this position where you're like, why is this happening to my body? And so, I was doing traditional HRT. I was, I used patches, I used pills, I used Biest for a while. I'm not proud of that. I tried everything, it was really like, I want to see what happens. Like, that was the beauty of having, the space to try things out and patients that were willing to go on the journey with me. And I think when you're a good enough care provider and you have their best interest at heart, like, then you can learn so much, right? In that discovery. And so that's really the space that I was in. And I got a very special patient. She was 48 years old. And at the first visit, I loved her so much. She actually was a nurse. She was a nurse practitioner who never practiced as a nurse. Never practiced as a nurse practitioner because she had kids with some different needs, and she ended up staying home and raising them for 20 years. But she had just gone back to work in the last couple of years as a school nurse. She walked into my office, and with the first 10 minutes of meeting her, I said, "Do you want to work for me?" Because I liked her so much. Just like one of those personalities and those connections where you're like, I can't let this person out of my life. I love her. And, she had found me because she knew she wanted a Dutch test. And we can talk about that later if you want. Like, there's a lot of debate, and I don't use a ton of Dutch testing, but it's something that, is a tool in my toolbox. But just, I'm saying that, and I say that to the audience because I want you to know that, like, she didn't want the Dutch test because she thought that it was going to hold all the answers, but she wanted the type of provider that she thought ran a Dutch test, right? She wanted the type of provider that was going to look at more and that wasn't just going to offer her birth control. And like, for people out there who are consumers, it can feel very black and white, right? Like, you're either in this camp or in this camp. And so it's like, you start to associate certain things with like this type of provider and certain types of things with this type of provider. And I think we get to redefine that for people for sure. But like, there's no reason to make anyone feel bad because they like desire to find someone that, for example, runs a Dutch test or compounds hormones, just because to them that feels like safety for whatever reason. Right. So all that aside, she was deeply in perimenopause. She, at the time, we didn't know this, but she, had adenomyosis, heavy bleeding, lots of metabolic resistance, and she'd always struggled with her metabolism. But of course, in the last 3 to 5 years, it had really fallen off the rails in perimenopause. All she'd been offered by her traditional GYN were traditional birth control methods, right, for managing her symptoms. I'm not proud to say this, but when I did her testing, right, her day 21 labs, and I did do Dutch testing on her, like, everything looked like her estrogen was like in the black. It all looked like it was normal levels, right? And this was years ago, right? So this was at the beginning of me kind of crossing the threshold, because she was patient 0 for me on PHRT, and this is why. But like, it wasn't adding up. Right. So the more that I was understanding about like why we have metabolic fall apart and how much that's tied to estrogen behavior, right, the more I was like, this doesn't make sense. Like, what is behind this? And at the same time, we had CGMs coming out. We had Mirror Monitor coming out. We had all these tools with which we could start to correlate more data and see like how, like, just because someone's having a 28-day cycle doesn't mean that the rhythm behind it is normal.
Struggling with mood swings, low energy, weight changes, or feeling dismissed about your hormones? You're not crazy. You're in midlife. I'm Dr. Rebbecca Hertel, board-certified osteopathic physician and certified menopause practitioner. And at Osteopathic Midlife Health, I offer personalized concierge telemedicine for women in multiple states, helping you navigate perimenopause and menopause with expert care focused on hormones, weight, sleep, libido, and more. My approach blends evidence-based medicine with a deep understanding of longevity and precision midlife health, because this phase isn't just about getting by, it's about thriving for decades to come. So visit www.osteopathicmidlifehealth.com and let's build your roadmap to lasting vitality.
We were monkeying around with all different things with this poor woman, right, for months. And I think about 6 months in, I had started her on some like low dose estrogen, like all the things that I had been taught and that I understood were like acceptable to do. It started her on that. Of course, we did progesterone first. I did all the functional things. She was an amazing patient. She's a math major in undergrad. So she's like a very, she follows all the rules. Best patient ever. And it's not, and we just weren't getting like the turnaround that we wanted. And she came to me one day and she said, I think I found the thing that we need to do. And I was like, tell me, what is it? And she said, I found this pharmacy and they do this method of hormone replacement that's different. And like, I already set up a call for us and we're doing a training on Friday. And I was like, okay. And so I didn't really know much about it. I knew that there were people out there. There were a few health coaches on the internet at the time talking about different dosing strategies with HRT that I didn't fully understand. Because again, most compounding pharmacies, right, even they had kind of like a threshold of what's normal. Like you would never give more than, 3 milligrams of estrogen a day, right? Like there were sort of like imaginary boundaries, right, that everybody sort of followed. And I just stayed within those, right, and tried to use all these other tools, just like so many other people. I think especially when you have functional training, you're just throwing like everything at stuff, right? And so, we go to this training and, right, I'm a midwife. So, and I read The Red Tent when I was like 19 years old and I read Taking Charge of Your Fertility when I think I was 22. And so I have like the foundations for me entering healthcare were very much grounded in physiology. I went to see Ina McGaskin speak when I was, I think, about 22. And I sat right at her feet and, she talked and said all these things. And I went home that night and I pulled out my Mirena. And I never did hormonal birth control again. And it wasn't like, not everybody needs to do that. But for me, it was like, I felt like I had been told my whole life that you aren't responsible enough to know when you're fertile. Like I felt like I'd never been given the option to be responsible enough. And so in that moment, what I felt was like, no, actually, I think I can hold the sovereignty. Like I'm a big girl. I can do that. And I want to do that. Right. And so those are the sort of precursors to me becoming a midwife. And my whole, shtick in midwifery was also like, I had my babies at home. You don't have to, right? I delivered babies in hospitals. You need to give birth wherever you feel safest, right? And the most important thing that you experience is how you feel, right? I don't care if you choose to have an epidural, if you choose to have an elective C-section. The most important thing for a woman when she gives birth is the way that she was made to feel, right? And so that was always kind of my intention coming into all of this. But I had this background kind of respect for the fact that, especially with birth, like for the most part, like physiology has a lot figured out, right? Like the body, the first intervention in birth is leaving the house, right? You're interfering with the brain chemistry when you leave the home, right? And you're changing stress chemicals, et cetera. But a lot of times, if you respect birth, and of course, many times we do need intervention, but like when you look at the World Health Organization data, it's a very small percentage of births that need to be intervened upon, right? We intervene way too much. So I always had this understanding and kind of knowledge that like the body has over time throughout evolution figured a lot of things out, and it does a lot of things with intention, right? Nothing is like accidental. And so when I was being presented this method of hormone methodology that like really respects the fact that the way your estrogen peaks before ovulation dictates a cascade of physiologic effects throughout the body, like it made so much sense. And it made so much sense to me why someone with a 28-day cycle, right, with relative estrogen sufficiency, or even, God forbid we say the word dominance, because we know that's loaded and like it's always because of something that came before on day 21 doesn't mean that the body was doing its job, right, on days 1 to 14. And so it made so much sense to me. And I had a willing patient who was saying like, please let me do this. And I'm never going to stand in the way of someone saying like, this is what I think is right for me. And so we went forward with it and her whole life changed, right, within a month. And we'd been throwing everything at this poor woman for the last 6 months, right, and not making progress. And I also think that like when we're in our 40s still, the brain is even more demanding of physiologic levels of hormones because it's what it's had, right? It's what it was expecting, which is why I think like starting someone on a 0.025 patch at 43 years old is like, seems like the right thing. Let me just give you the lowest dose because you only have a little hormone insufficiency. It's actually like, I think it's counterintuitive. And what I often see is when you do that very low dose, they might feel better for a month or two, but then you start to suppress their own pituitary action. And then they end up like walking around just at a level of like 80 every day, which is very anti-physiologic, right? That's not really what your hormones are supposed to do. You're supposed to 4x your hormones, right? 2 days before ovulation. And that 4x, that physiologic peak, right? It triggers collagen formation and bone turnover and growth and neurotransmitter function. And like all of those functions we like to talk about with estrogen don't happen every day, right? They get kicked off. There's a catalyst moment for that. And that's when we peak our estrogen in pre-ovulation. It's also what primes the uterus, right? For the primes the progesterone receptors, right? So what I found was like, oh my gosh, this woman who's 48 and having massacre, like bleeding all the time, who really doesn't want an IUD. Like she just really does. That's why she came to me, right? Because she wanted another option. She didn't like the way she felt when she had that. Oh my gosh, you give her more estrogen and you peak her estrogen, her receptor function comes back and she has like normal bleeding with no cramping, like no heaviness, like it's completely normalized. It's higher estrogen that's needed, right? So like that whole idea that like estrogen, more bleeding is not, it's just like such a minimal part of the story. There's like so much more than that. So I hope that answers your question.
Yeah.
That's so interesting, Emily. Can you tell us a little bit about how you do it? How does that work for you in clinic? What do you tell the patient to do?
Yeah. So we compound estradiol at 10 milligrams per milliliter in a toppy click. And so each click of estradiol is half a milligram. And so depending on where we start someone, like if they're still, if they're still ovulating and they're just, kind of say like you look at when we do mirror charts, sometimes it's not necessary because usually you can piece this together on your own, but a lot of these patients kind of want to see what's happening and it's fascinating to look at. So a lot of times what you'll see, I think about 8 years before menopause, what we often see first is this like flattening out of the follicular phase estrogen. And I've just seen this in enough charts and kind of talked to the people at Mira as well. And this seems to be a common theme. So you see this flattening out of the curve, and this is where you see the metabolic and the brain fall apart happening, because without that peak, like they're not getting the insulin resistance is starting and the visceral abdominal fat is starting. And, some of the circadian rhythm stuff is falling apart and some of the mental health stuff is changing. So with those people, I might start them on like 1 or 2 clicks twice a day. So they're just getting like a milligram. And then when we get to days 10, 11, and 12, we're bumping that up. So they're getting up to like 8 milligrams twice a day on day 12. And then you drop it back down, like drop it by half, maybe to 4, and then back down to 1, and then kind of come up and maybe do 2 milligrams twice a day for the rest of the luteal phase. And you're bringing in progesterone at that point as well. And so we're following it, and we're looking for a day 12 estradiol level or day 13. So either like 4 hours past the morning application to see sort of a peak level, or sometimes I'll even check a trough. So like the trough not being lower than 300 for your total estrogen, and the peak, not being above like 450 to 500. But I will say there's a lot of bioindividuality for that. And some women just, they see, and like everyone has kind of a tell. Like for my patient 0, for my first person, insomnia was like her biggest thing, right? Like she just knew that there was like something distorted with her sleep. And it wasn't until her peak estradiol was like 600-700 that corrected. Now that means like day 21 is a much like more kind of normal level, but it's that single peak that's so important that really changes the physiology going forward. So we check a day 12 and we check a day 21, and we do that at 12 weeks. So we do 3 cycles, right? And then in the 3rd cycle, we're checking day 12 and 21. We may make an adjustment, like if someone is, really symptomatic, like you can tell in the 1st cycle, if they're very symptomatic going from day 12 to 13 to 14, when that level is dropping, then you know that their baseline is too low, right? So we may raise them up in the 2nd cycle. But generally, like we're kind of, we're moving along and we're waiting until the 3rd cycle just for the whole, HPO axis to adjust, because there's this new kind of big exogenous input happening. And we're doing a lot of this just because I think of the demographic that I've ended up serving because of who I am and where I am and the people that I know. We have a lot of people in perimenopause come to us. I think also because disproportionately, like they're typically offered birth control. Like that's a thing that they're offered, especially if they're still menstruating. Or they're trying like a low dose option and it doesn't, they have that scenario that I talked about where they feel better for a month or two and then like kind of the wheels fall off the cart and they, are either having a lot of irregular bleeding and then they're being told like that their only option is an IUD, right? And they're sort of like, this doesn't feel right. And so they end up with us. So we do get a lot of people in perimenopause, but we do this with fully menopausal people as well, which is a whole other story.
Yeah, I bet you I bet you it's the same pharmacy because we got introduced this by some menopausal women and Rebbecca and I, right? I don't know, Aoife, did you do that? I know Rebbecca and I did that meeting, and so it was kind of intriguing. Of course,
Really
my whole motto is life's too short to bleed. I couldn't wait to blast that line shut. So I'm like, gosh, that's the last thing I want to do. But the people that we know that do the physiologic in menopause, they say they feel great and they love it and it works for them.
Want the Dusty Muffins at your next event? We do panels, live podcasts, and talks that bring the heat, literally. Corporate, CME, or retreats, we've got you. So hit us up at thedustymuffins333@gmail.com or DM us on Instagram at thedustymuffins.
Yeah. Yeah. And it's not for everyone.
Tool,
like,
right? Yeah. Another
it's
tool.
Definitely not for everyone. I make a lot of analogies to home birth. I just can't help myself because I was in that world for so long, but it's the same thing. It's never going to be more than a certain percentage of the population that wants to take that on because there's such a level of personal responsibility around that. You have to order your own peri pads and you have to, you have to get your own cord clamp and all these things. Not everybody wants that complexity, right? And that responsibility, but some people do. And, for the people who had one of the most common things we see is people come to us and they have this history of heavy bleeding and perimenopause. And so maybe they've got their bleeding suppressed now with something. They're afraid to do PHRT because they don't want to bleed again. But the PHRT bleed is a 3-day, very not big deal bleed. And the reason I like it is that the bleed is a proxy for what's happening in the rest of the body.
Do you do it with your with women who don't have a uterus as well? Or you're just doing lab work or right? Because then they don't bleed at all. So then you're just following labs for them, when you're starting, or at least initially.
Yep. Yeah. We would always do labs every 6 months. We start with every 3, and then once they're
until you figure out what they're.
Yep. Every 3 on 2 different days, right? Because we're looking for different results on day 12 and 21. And then at the point where they're really coasting, if someone's doing really well, we could knock it down to every 6 months, just one lab. And we would alternate. So do a day 12 once, and then 6 months later do day 21. But that will take a couple of years. So it is more lab monitoring. But it feels necessary to me. If we're going to be doing this kind of dosing that we know what we're dealing with. And it takes a lot of communication. If a patient is going to be really irregular with her cream application, or if she's not going to be communicative, we can't do, we have to say,
you need that patient. Yeah. Who's going to be, sure. And kind of, go ahead, Aoife.
I was going to say, Emily, what are you doing with the progesterone during this?
Yeah. So it depends on the person. So I always like to say, I'm not the hugest fan of transdermal progesterone, but I don't think that it's the witch hunt that people make it out to be. The fact is we really don't have research on more than dosing of 40 milligrams for transdermal progesterone. So to vilify it and say that anyone who prescribes transdermal progesterone is doesn't know what they're doing is just not fair. And so you can do transdermal progesterone. It's not my preference in someone who's not ovulating, but it does work well for women who are still ovulatory, especially because a lot of our women like to identify that ovulation has happened and then start their progesterone afterwards. And they only need a little bit, like that first case I was talking about where maybe they're on a low dose and we just give them that peak, and the peak is what really needs to be replaced. Their ovulation will actually become more robust if you track it, and they're getting better progesterone, endogenous progesterone secretion initially. And so maybe they're supplementing, but we're doing robust doses of progesterone. This is not 50 milligrams, right? We're talking about For someone who's on where we do the protocol is initial, and then it goes up 1, 2, 3, 4, 5, down to -3. So someone who's on like a +2 or +3 E protocol on your day 21, your progesterone dose, whether it's transdermal, vaginal, or oral, is going to be somewhere like 400 or 600 for a day, right? But that peak progesterone is really important, right? And there's also a lot of physiologic signaling that comes from a peak day of progesterone, like the bone solidification happens from that peak of progesterone. P53, tumor suppressor gene, comes from a peak of progesterone, right? There are studies that show that when women who have a lump, a lump, a cancerous lump in their breast, have that lumpectomy done right after ovulation, before progesterone surges, that they have a lower risk of recurrence, because you get this surge of P53, which kind of cleans up any like tiny little cancer cells that might still be there. So there's a lot to be said for cycling progesterone and for giving someone a peak, right? Instead of just like a static kind of, it's not just 14 days of 200, right? We're giving a nice robust peak. So my personal favorite is vaginal. Again, the naysayers will say like, we don't have any evidence. And like, we have evidence in pregnancy that sustains the uterine lining. Like, what more evidence do you need? It's just like insanity. But I love vaginal progesterone. Some people don't like, it's a little messy for them. I like compounding it in olive oil. It's like very compact. Suppositories work also. And you can also do it rectally. Like if people are really fussy about the discharge, I don't mind. I feel like once you've had 4 babies, like nothing phases me if it comes out of my vagina.
Yeah.
Being honest.
Can I have a little bit of something?
Slip and slide, like it doesn't, it's just like nothing. It's not a big deal. But some people don't like that. So rectally works really well for them.
Yeah.
I like that because I actually find that when you're giving it vaginally or rectally, like the levels stay more consistent and people aren't going all up and down, because when you're only cycling progesterone and not giving it daily, it's hard to achieve that half-life, right? If you're giving it daily, it's different. Like it's going to build up in the system and the liver is not going to process it all out. But if you're giving it for a contained period of time, like your liver is processing the crap out of that. And then I'm just seeing that a lot of women, if they're taking it every night, because orally is dosed once a day, even if we take out and give them like 50 milligrams in the morning and then the bulk of their dose at night, by like 4 p.m., they're feeling like a withdrawal effect almost. They're feeling anxious or kind of like that itchy low progesterone feeling of like they need their fix, right? And their brain needs that allopregnanolone. So for some people though, like their brains just, there's like physiologic applications of hormones and there's therapeutic, right? There's ways like that some people, maybe they were always feeling a little bit off, but actually taking oral progesterone where you're going to get a much higher percentage of allopregnanolone than you were ever exposed to endogenously from your periods. Maybe that's good for their brain. Maybe that like helps whatever kind of quirk they have or whatever thing is theirs. But that is true. Like when you take a large dose of oral progesterone, you're getting more allopregnanolone than you ever would physiologically. So it's not a natural, like physiologic hormonal milieu, if you will. Yeah.
Yeah, I know. I agree. It really is. And I guess you could, if you wanted, for those women who, menopausally are nervous, and you can do an ultrasound or something like that if you're wanting to.
We do. We actually require pelvic ultrasound annually. And for women that have like a history of obviously if there's anything questionable, we're getting an ultrasound before we even start. And, obviously for older women, we're making sure that they have all of their cardiovascular workup and all that stuff as well. But there's a doc out on the West Coast who's one of the original PHRT prescribers. And he has found that like women who were told that they needed triple bypass will have all their cardiac plaques resolved on PHRT. Like in 6 months on PHRT, they have no need for bypass surgery. Like it is quite miraculous actually what can happen when you restore the physiology. This is just, it's so funny because there are all little pockets of medicine like this, but it's just, there's all these people that have kind of been doing this like underground for years, 20 years, like through the dark ages when no one else was prescribing hormones, seeing these incredible results. And like, they're not on Instagram, you guys, they're just like out there, like changing the world one woman at a time, and nobody knows about it. Right. So I don't know. I'm at the point in my career, you probably agree with this, where it's like, of course, I'm like always looking at the newest stuff that comes out and I'm interested to see what people are researching, but I'm also most fascinated by the people that have been out there for 20, 30 years practicing this. And like, what do you see? What are the trends and patterns you see? Because like your brain, there's only one of them. And like what you've been exposed to in the thousands of patients that you've treated, like we become like a computer, right? For all of the things that we've collected in the data over time. And I just think that like, yeah, that's where I find that I learn the most eye-opening things.
This almost sounds like it might be helpful for some women who are finding it hard to get pregnant because they're ovulating so infrequently.
Yeah, it's such a good point. I have used it in fertility cases. It's fascinating, actually, when you do PHRT for 3 months, follicle health improves, AMH gets better, and you can take them off of it. Or what I've done is I'll reduce the dose by half and pair it with a low dose of Clomid. And so they do kind of both together. It kind of functions like Clomid. I mean, that's essentially what Clomid does, right? It supercharges the ovaries and you get this robust kind of rising level of estrogen. So together, it's fascinating. It works really, really well. And then the vaginal progesterone translates really well to that as well.
Have you been told your labs are normal, but yet you still feel exhausted, foggy, and gain weight simply by looking at a meal? Well, you're in good company. In midlife, normal isn't enough. You deserve to feel like yourself again. I'm Dr. Christine Hart Kress, a board-certified women's health nurse practitioner and certified menopause specialist. I deep dive into the areas often overlooked: hormone optimization, thyroid health, gut health, medical weight loss, including administering testosterone therapy for women. No rushing, no insurance hoops, just a blueprint back to a vibrant life. I'm accepting new patients in Virginia, Florida, and 5 other states. Book your clarity call at www.christinehartkressdmp.com. Yeah, I think so many people don't know about the crinonone, the vaginal progesterone. I see that out on some of the Facebook groups, and patients will bring it to the provider and they're like, it's not even endorsed by the Menopause Society. Not that I care what the Menopause Society says, but it actually is endorsed by the Menopause Society. It's just patients either love it or hate it because of the mess. So, yeah.
But you can even use oral prometrium vaginally. If you use the cream squishy one, not the orange one, that one will dissolve vaginally and rectally. And I get pretty good serum response from those. I personally like the compounded better, but if someone can tolerate the regular commercial prometrium, like we tend to order that because it's covered. And then the pharmacist, of course, calls us and is like, "Do you really want them to place this vaginally?" I'm like, "Yes, I do, sir. Yes, I do."
Thank you. Yes, please, and thank you.
And the end. Don't give her the orange footballs, please. Don't give the orange footballs.
The little white pearls, the little squish.
Yeah, they work really well.
Mm-hmm.
They do. Yeah,
it makes a difference.
Yeah, absolutely. I mean, it's just common sense. Like so much of this is that it's common sense. Like if we're all trying to, I think the more that we can mimic nature and like what we're doing, there are obviously times when, more advanced pharmacology and things like come into play and align with a woman's preference for sure. But I find personally that like, if I'm looking for that systemic response and I'm looking to recover the things that have been lost through the perimenopausal transition, it's like night and day what I see if I'm dosing hormones physiologically versus like in a symptom management approach.
Do you feel, do you have anything, Emily, during this phase of life that you wish someone had told you kind of straight earlier on in life?
Wow. I think this isn't really exactly, but I do sort of wish that I had slowed down more when I first had my kids. I wish that I had just not tried to work full time as a midwife while having babies. I just think that there are some things that did to my nervous system and my glucose system that I'll never fully recover. And it's like something that I'll try to pass on to my children and hope that like they feel the freedom, to step back, because there's just so much life after that. And I think when I was in grad school, we were being raised to be little soldiers in the medical field. And especially as midwives, the message was like, no one else is going to do this. Like, you have to protect birth. The world is on your shoulders. You've got this world-class education. Now go out and change the world with it. Otherwise you'll be a disappointment to us. That was the message that I got from sort of our older Gen X instructors was kind of the age range. And I understand that like in the 80s, it was a different world, and like midwives really did have to fight for our profession to survive. But that I would say that was maybe damaging to me, and that like I could have taken my time. It wouldn't have been that big of a deal, if I decided to just work in a clinic once or twice a week instead of being on call 1 in 4, which is what I did for 5 years. 5 occasionally, but someone's always out with a hip replacement or something. So it feels more like 1 in 4. With regards to midlife, I don't know. I had the good fortune of getting into this right at my own cusp of midlife. I wish I had known a little bit more about how the metabolic, hormone connection. After my third baby, I was a gestational diabetic in my third and fourth pregnancies. So both of my over 35 pregnancies. And I didn't understand it as much then, and there were no CGMs. I wish that we had that. But I think that if someone had told me at any point that like, if your metabolism isn't working, it's like a lot of it, yes, we have to change our behavior, but also there are sometimes things that we can help women and give them quick wins where it makes the behavior like easy, and nothing should feel that hard is kind of the message that I wish I understood even 5 years ago. Like, do you know what I mean? Like how much, like what a relief that is for us, like overachieving women that feel like if we don't do it, it's not going to happen. And like, if something's gone wrong, it's totally our fault. Like it's our dysfunction or, shortcoming that has made it come, happen that way. I think that I really hope that my daughter doesn't carry that burden. Right.
So, Emily, you recently had a post about the Mirena IUD that sparked conversation online. And what was the core message that you were actually trying to get across with that post?
Yeah, I think it was very misconstrued because, I was basically called a fascist for suggesting that, birth control could be oppressing a woman's rights. Obviously, that maybe sounds counterintuitive when you first hear it because we think of birth control as liberation. And I had a Mirena IUD. I put in hundreds of them. I, also graduated from school proselytizing the benefits of the IUD. And we know that it works really, really well for bleeding and that it's a great tool. I think that what I was trying to say is that so many people in midlife, or maybe they're having bleeding issues, but they have this core knowing inside of them that like something else is off and that the bleeding is just an example of an internal dysfunction. And we miss the opportunity to really investigate and support and correct the thing that's going on hormonally upstream when we just treat the symptoms. When we just mitigate the bleeding and suppress the bleeding, we miss the opportunity to say, oh, hey, look, like you're not peaking your estrogen at all. And it's causing, right, decrease of inhibin and, erratic estrogen behavior. And the list goes on, right? It ticks off a chain of events when that doesn't happen. And we neglect all of that when we go all the way to the bottom of the chain and say, like, just fix the bleeding. And like, okay, maybe we fix her iron that way. She's not bleeding, her hemoglobin is better. But we miss the opportunity to address like the core hormonal issue that sparked the bleeding in the first place. Mm-hmm. And it's not for everybody, but some women would really like that investigation and would benefit from a treatment approach that considered it.
And is there a way, if a woman, wants that IUD for birth control or heavy periods, that she can still do the hormones first care, or they don't work well together?
Like do physiologic HRT? Generally, physiologic HRT doesn't work well with a Mirena because you don't get that receptor activity that you really need, right? You can't peak an estrogen level if you're not then going to be using cyclical progesterone. But you can certainly dose her estrogen higher, right? You can give her that, but then she misses the opportunity to get progesterone, right? Because you can give a little progesterone, but I think you can't really dose progesterone in a really high or physiologic way when you have a Mirena. People end up feeling pretty crappy when they do that. Yeah.
You give it that
do you guys find that? Like, do you add progesterone on top of a Mirena very often, like in high doses?
No, not in high doses, 100 or 200 milligrams usually.
Oh, still like do you think people do okay on 200 milligrams on top of the Mirena?
Yeah, they do great usually.
But there's always tricky cases, right? Where it doesn't work. And you're
Always.
like, what?
Always.
Yep.
So,
Yep. That's always,
Mhm.
that's why I think it's just always important to have either colleagues that have different tools that you can refer patients to, right?
Yeah.
Hey, I have someone that does this. I wonder if you'd be a really great candidate, or you have it as part of your own toolbox.
Yeah, totally.
And that's just so great about like collaboration and
Mhm.
having, you know, colleagues in this space that have such different twists or turns or thought processes or just different ways of doing it.
Yeah.
That's probably one of my most favorite things about, you know, meeting new colleagues and having such great discussions with colleagues. It's not about this is the right way and yours is the wrong way, but it's about how, you know, all women are so different. And so when we have the ability to give so many different options, I think that's then the women win, right? Our women win, our patients win.
Totally.
So that's so important.
100%. And I think like ultimately we all want to give women the autonomy and the sovereignty to be able to make all the choices that they want. I think I've seen so often, and I was this provider at one point, that there's something specifically about LARCs where we become in certain medical environments very dogmatic about like, don't ever take that out, or like refusing to take it out if a woman requests. And I think that kind of like power struggle can become a little bit difficult. And a lot of women feel, you know, disempowered when they have that situation, or like not believed, right? When they really believe that they had a set of symptoms that started when they got something, and then they're being dismissed and told that like that's in their head and that it's not systemic, and, you know, that can't be real. That's problematic to me. I'm sure none of you do that.
No, but we see it.
Yeah, of
Yeah.
course.
Yeah.
Mhm.
And our patients come to us because of it for sure.
Totally.
Mm.
Yeah, right.
so Emily, what can you
Um,
tell our listeners how they can find you if they're interested in learning more about the amazing work that you are doing?
Yeah, absolutely. Thank you. So I'm obviously on Instagram at Emily Sadri _NP. And you can check out my practice, AureliaHealth.com. And we're in a whole bunch of states. You can put it in the show notes, maybe about 15 or 20 states now, something like that. And yeah, thank you so much for having me, you guys.
Oh, thanks for being here and being willing to tackle the controversial topics with us and bringing some nuance back to the table.
Yeah, I love it. It's great.
Thanks, everyone. And thanks, everyone else, for listening. Don't forget to like and subscribe, and we will see you all next time.